Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be moderating today's session. Our speaker today is Dr. Nicholas Leyland, and his seminar is entitled Medical Negligence in Gynecological Surgery. Before I introduce today's speaker, I'd like to let you know that this seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speaker. Dr. Leyland is a professor of Obstetrics and Gynecology at McMaster University in Hamilton, Ontario. He has recently completed 2 terms as chair of the University Department of OBGYN and as chief of OBGYN for the Hamilton Health Sciences Corporation. Dr. Leyland graduated in medicine from the University of Toronto as the Cody Silver Medalist and completed a Master of Science in Healthcare Management from the Harvard School of Public Health, summa cum laude. He has created the McMaster Endometriosis Center of Excellence for the care of women with this complex disease. He has more than 200 scientific papers, clinical practice guidelines, and book chapters published. Now it's my pleasure to pass it over to you, Dr. Leyland.
Thank you very much, Andrea. It's a pleasure to present this interesting area, and I find it very interesting, so I hope you will as well. Today, I'd like to look at presenting and understanding the elements of medical negligence and the ethics of informed consent and care. What does this entail? And it's an extremely important area. And then the issue of medical errors, quality issues, and how they relate to litigation. So the fact is that surgery is a risky business. And this talk, I give it mainly to gynecologists, but I've made it a little bit more generic. So it's really about all aspects of surgery, but it can be actually related to medicine as well. So elements of medical malpractice. There are 4 elements to every malpractice case, and each element must be satisfied for the plaintiff to win a case. So that's why, as you will see, it's really difficult for plaintiffs to win cases. So the first is duty of care. Next is the breach of that duty of care to patients. And there has to be an injury that took place, and then damages that are defined by the nature of the injury and how it impacts on the patients and their families, etc. So this little slide says, I don't feel quite as fulfilled when I've saved a lawyer. There is this kind of adversarial perspective between medicine and the legal profession, but I don't believe that ought to be the case. So let's look at the elements. First is the duty of care. A duty is a legal duty exists whenever a health provider undertakes the care or treatment of a patient. Now, as obstetrician gynecologists, we have a duty to evaluate all patients who come in through the emergency room, much like many other emergency physicians, etc. We can't choose who we're going to treat and not treat there. But other physicians, including obstetricians, may choose not to see a patient that's being referred by another provider, a family physician, midwife, or a nurse practitioner. And so you don't owe a duty to that patient. But the CPSO has made some changes in 2019 where we have to inform the provider within 2 weeks that we will not be seeing that patient. And this is where we're going to see change over the course of time, where physicians are going to be actually required to provide care to patients within a region, so-called value-based healthcare system, where we as physicians will no longer have the opportunity to say, no, I'm just not going to see that patient. This is already beginning in other provinces, particularly in Quebec, but it remains to be seen how this is going to change. And this doctor is telling his patient, to avoid lawsuits, we now refer all patients to other doctors. So element 2, the breach of the duty. So it's breached when the provider fails to conform to the relevant standard of care. So this is what the lawyers call the standard of care issue. And the standard of care is provided by experts and their testimony in court. And that's based on national standards of the profession, as well as what's called the locality rule. And so the locality rule is about that the doctor must exercise a reasonable degree of learning and skill ordinarily possessed by surgeons in the locality where the doctor practices. So, and those are based on their peers. So when a plaintiff is getting an expert, a plaintiff's lawyer, they are looking to find someone who is equivalent or considered a peer to be the expert witness. And the same thing for the Canadian Medical Protective Association. But the locality rule, this allows some leeway for physicians who are practicing in rural areas or areas that may not have access to consult expertise and other medical knowledge and equipment. So the national rule, however, is where the physician has a duty to use the degree of care and skill that is expected of a reasonably competent practitioner in the same class to which he or she belongs, acting in the same or similar circumstances. And these are generally based on accepted guidelines. So I've been involved in guideline development for the Society of Obstetricians and Gynecologists of Canada, and it's an extremely rigorous process because we don't want to make it difficult for physicians to practice. And we also want to educate physicians in what's new and changing in those particular guidelines. But if an area lacks facilities or specialized expertise, the patient should be advised of where to seek the facilities and referred there if the patient desires that, or if they choose to do that. So element 3 is what we call injury. So the breach must cause some injury, and the breach of the duty must be a proximate cause of the injury. That's a medical term, and I'll tell you about it briefly. But here's a couple of examples, and these are from real cases that are completed. So an MD fails to order venous thromboembolism prophylaxis on a high-risk surgical patient. So an oncology patient, a patient who has a number of comorbidities that place them at high risk. The patient then has a pulmonary embolism and has significant debility related to that afterwards. So that one, the plaintiff was successful. But in this one, an MD orders a drug for ovulation induction and the patient has triplets. They are delivered severely prematurely with multiple issues and morbidities, and they sue for compensation. And this has gone to the court, and the patient was unsuccessful because of the issue of proximate causation. So actual and proximate causation in English, what this means is you need to have a link between whatever happened and the injury. So what happened is the care provided by the provider and the injury needs to be connected. And the analysis of the actual causation element involves what's called the but-for and the foreseeability test. So this is often legalese and language, but for the provider's action, injury would not have occurred. And foreseeability. So the injuries that the result of the provider's actions were the result of the provider's action, and the injuries were foreseeable before the injury occurred. It was one of the issues that's predictable, but unfortunately, because of the care that was provided or the lack of care, the injury occurred. So actual and proximate causation, just go into this a little bit more. A patient came to the medical office for a history and physical. The resident took the history and noted that there was a remote history of an ulcer with no recent complaints. The patient came back later complaining of back pain, and a physician read the resident's history and initiated aspirin therapy. So the patient developed gastrointestinal bleed. The patient sued the staff doctor and the resident for failing to diagnose an ulcer and sued the physician for failing to order an endoscopy before starting the patient on aspirin. The court found for the resident and the staff physician in that case, because the patient, through their lawyer, had failed to prove a direct connection between the patient's GI bleed and the failure to diagnose the ulcer in order to order an endoscopy earlier. So the patient or the plaintiff failed to prove actual and proximate causation. So when all of these things are breached and causation is proved, then you have to prove an injury or harm. So the injury must be demonstrable. So, and that's on the basis of medical documents, again, expert testimony, and direct evidence of pain and suffering. And sometimes the insurance companies or other people will try to videotape somebody doing what they say they can't do to disprove their claim for injury or harm. And damages. There have to be some damages, losses which may be physical, financial, or emotional, and where there's no basis for a claim, regardless of whether the medical provider was negligent. So if nothing really comes out of it, there are no damages, then the patient doesn't receive any monetary compensation. And this is an interesting one, obstetrical injuries that can lead to birth injuries. So some American colleagues in the legal profession will actually solicit injuries from patients. And here actually they talk about fetal distress, placental abruption, placenta previa, which is interesting actually. This is not placenta previa. The placenta would have to be down here if it's placenta previa. So what about the principles of informed consent? So when we are looking after patients, we have to have a really significant dialogue about proposed interventions for their health. So number one, an assessment of the patient competence to make those decisions is important. And then disclosure of relevant information, risks, benefits, alternatives, and in some cases that may be not intervening. An assessment of the comprehension of that discussion, and then affirmatively obtaining consent from the patient or their surrogate. So informed consent must occur before a patient or a surrogate signs anything. And it's important for providers to know that informed consent is not just a signature on a document. So in fact, the signature on the document is that they've actually agreed to they've had the informed consent, but it is useless in a court of law. What informed consent is documentation of this type of dialogue that you've had with the patient, pointing to a consent form that their signature is on it is actually insufficient to protect the physician. Those forms that are required in a hospital are requirements of the Public Hospitals Act, that everyone undergoing a procedure or intervention has to sign that sort of thing, but it is not a truly informed consent. So what about the ethical perspective on informed consent? So remember the principles of beneficence. So trying to maximize benefit and minimize harm. Non-malfeasance, so first, do no harm. Justice, so all equals should be treated equally. And then autonomy, which is an interesting concept, particularly in view of some of the events going on in Windsor and in Ottawa now. And it's all about autonomy with respect to mandates for vaccination. So beneficence. So the physician must have the best interests of the patient in mind and should be minimally influenced by other concerns. And I put the $ up there. Fee for service is one of the most perverse ways of paying physicians. There is no other better way to pay them, but having them directed to do certain things on the basis of the fee schedule is, I think, a terrible thing. We need better ways to provide compensation to physicians, because there is no doubt that utilization of various interventions is influenced by finances for physicians. And when it comes to the patient really has to trust that the physician is their advocate and agent. And I always tell patients that the golden rule of medicine is that I want to look after the patient the way that I would want to be looked after. And obviously I'm a gynecologist, so more importantly, my friends, family, or loved ones are looked after by a physician. Non-malfeasance, so first, do no harm. We're not supposed to intentionally harm or disadvantage a patient. And the patient must trust that we will not willingly harm. So that's why I have that discussion with the patient. Things can go wrong, but we're going to do everything possible to minimize that risk for the patient so that it becomes what we call an acceptable risk. And the concept of the acceptable risk is really difficult for many patients because they don't want to take any risk. Well, I often say, well, you do take an acceptable risk every day. If you drove here to get to the hospital to see us and to talk, you took a risk, but that was an acceptable risk. You knew that driving, you could get into an accident, be harmed, or even killed. But it's so unlikely that you're willing to accept that small risk. And surgery is like that. And what about justice? This principle is the prohibition against denying benefit capriciously or by selective criteria. So everyone should be treated equally. And autonomy. So here's the thing that's really coming to the fore recently is about self-governance, being one's own person without constraints either by another person's action or by psychological or physical limitation. So this is what is happening all around us right now, is people feel that they have the right not to be vaccinated, to choose that, but they don't have the right to put someone else at risk who is unvaccinated, or and we do frequently abrogate the rights of autonomy of children who are vaccinated and others where we've had many vaccine mandates for healthcare providers. I had to get my all my vaccinations up to date in my first year of medical school. So we do this for a lot of different people, but there are many people in our society who believe that that is wrong. Practical informed consent. So one of the things that comes in the legal world is what would the reasonable person want or need to know before they make a decision about proceeding with treatment. And that really is interesting because the way that the lawyers do that is they talk over and over with the plaintiff and they say, well, basically they want to get them to say, had I known this, I would have gone to have this, that the risk was so low, but unfortunately it did happen. So they have various ways of trying to get plaintiffs to say that. So what about documentation? So as providers, what do we need to put on our own documentation? Not that piece of paper that we signed. So the rationale why it's proposed, the benefits, the advantages of the treatment, the risks and the potential material risks. Those are the ones that if the patient knew that there was a really good chance of this happening, they may choose not to have that particular procedure. But if it's rare, then they should be If it's really rare that they're going to potentially die from this procedure, you can say that, but they would still go for the procedure because they know, much like the analogy with the car driving to the hospital, it's extremely unlikely. If everything goes right and if something goes wrong. And alternatives, what else can be done instead of operating? Medical therapy. And this is critical in our area of endometriosis. Our colleagues south of the border frequently are telling patients that the only treatment is surgery. And I believe that that is, at least in part, because surgery in the United States pays the providers a lot more, and they can rationalize their own judgment on this to provide surgery as the only option. But in fact, Canadian, the European approach is a balance between trying to reduce pain of endometriosis with medicine and trying to limit the numbers of surgeries that people have. So what else can be done? Even observations, so not intervening. What are the outcomes if we don't do anything? So what about the Canadian Medical Protective Association, which is the legal group that protect doctors, and most doctors are covered by this type of insurance program? Who are the people who are sued most? And so from the top 5, so emergency medicine, radiology, surgical subspecialties, general surgeon, and survey says number 1 is obstetricians and gynecologists. And the payouts for obstetrical injuries are probably the highest of any of them, because if a baby is unfortunately damaged at birth, they have their whole life to look forward to ahead of them. And if there is some disability, then that has to be compensated if the suit is lost. Which brings to mind another thing. If the suit is won by the defense, who helps to look after those babies? So it really argues for tort reform, how we deal with these issues. And other countries have a less adversarial approach to this issue. So what about the results of medical liability suits? In the Canadian Medical Protective Association, up to 2018, 65% of the claims were dropped, dismissed, or withdrawn. Almost or a little over a quarter were settled. Almost 5% were decided by an alternative dispute mechanism, and 5% were resolved by trial. But most of the time when they go to trial, the defendant, doctor, wins. So it's a tragedy for these patients because they end up having to spend a lot of time, effort, emotional time, and then it is harmful to them because they're just even more upset after losing. So this is from the Harvard Medical Practice Study. And what they found is that there are bad outcomes in surgery and in medicine. And here we have iatrogenic with fault. In other words, it is definitely something that the patient would win if they sued, because the physician practiced below the standard of care. Here, lots of bad things can happen in medicine without fault. In fact, the majority of bad outcomes are not related to poor practice. And here we have the filed claims. And what we see is that there is really a small percentage of claims that actually are filed that they win or have the potential to be won. And only 1 of 6 claims were filed were for negligent injuries. In other words, most of them are in here and they're not negligence. And that's what's really upsetting to patients, of course. So the legitimate focus of litigation is here and not here or here. And this is where communication and appropriate interaction with patients after the events happen, to let them understand that you feel badly about this, but it was not something that we could have prevented, can prevent them from going through the whole process and ending up just losing the case. So what about medical leadership and quality? So just shifting gears a bit, everyone hears about quality of care. And really, when you ask them, they really have difficulty describing what that actually is. Well, I'm going to tell you what the 6 components of quality are. So the first one is that it's safe. So people know about patient safety. So avoiding injuries to patients from care that's supposed to help them. It's effective. So working at McMaster University, we all hear about evidence-based medicine. So we want to use the best scientific knowledge possible to benefit patients and refraining from doing things that are not likely to benefit them. And there still is in medicine a lot of underuse and overuse of testing and various interventions. So it's important that we as care providers really try to choose wisely those things that we're going to be utilizing for imaging and interventions. It should be patient-centered, of course, and this is respectful and responsive to individual patient preferences, and that patients should be engaged in all clinical decisions. Timely. Now, here's a huge problem with the Canadian healthcare system, particularly with the pandemic. Reducing wait times and the backlog of surgeries, particularly interestingly in women's health, but in many others, is an extremely challenging prospect going forward. But all of the care should be appropriately timed for patients. And efficient, avoiding waste of equipment, supplies, ideas, and energy. And in fact, physicians are not particularly engaged in stewardship of the resources of the healthcare system. We need to do a better job in that area. And equitable, so providing care that doesn't vary in terms of personal characteristics, gender, ethnicity, geographic location, or socioeconomic status. We have a lot of work to do there. Canada is a huge country with large rural areas where access to healthcare is challenged. And certainly working in women's health, I know that there are tremendous gender issues in healthcare. Ethnicity and other characteristics, we need to do a better job. So to err is human. I don't know if you can see this, but this is a book that was published 22 years ago by the Institute of Medicine. And it estimated that 44,000 to 98,000 deaths were unnecessary due to medical error. And this is horrendous. And injuries, 1 million excess injuries where people were injured but didn't die. And the numbers were based on particular studies and extrapolated to the general population. So it is an estimate, and you can see there's a huge variation, but no matter what it is, if it's in there somewhere, that's a big deal. Because with those unnecessary deaths, there were 58,000 Americans killed in Vietnam, in the Vietnam War. And so, it's a significant number of people right in the United States. It's equivalent to 3 jumbo jets crashing every 2 days. And that's horrendous. If that actually happened, but we kill our patients and damage them 1 patient at a time, that's part of the problem. So errors are a serious problem. More people die from that than breast cancer, AIDS, or motor vehicle accidents. Now more people are dying of COVID-19. But there is a significant issue still with errors. And despite widespread national and regional educational programs, great medical schools, good training, the prevention about conditions and the medical prevention of error, it still happens. And why is that? In Canada, if we want to look at that from the Norton and Baker paper, at least 100 to 500,000 adverse events per year, estimated between 15 and 20,000 deaths from medical error. That's not from the disease that they came into the hospital for. And the cost of that injury exceeds all the costs of medical litigation. So we could really save a lot of money and headache for everyone if we dealt with the errors effectively. So how hazardous is it in healthcare? So if you look on the y-axis, the total lives lost per year and the number of encounters on the x-axis. So what you find is the safe or ultra safe areas are scheduled airlines, European railroads, nuclear power despite Chernobyl. And then you move down, chartered flights, not as good. Maybe that's why they're cheaper. Chemical manufacturing, driving is in here. Mountain climbing. One of my sons is a very safe mountain climber, and he has all kinds of great opportunities to educate me and other medical people how they communicate. So we've used some of those principles in communication in the operating room. But here we go. Here's the issue. Healthcare is way up there. And so it's a very dangerous sport. So, and I presented this once to a group of doctors and they said, no, but patients are coming into the hospital with diseases and everything else. And I said, no, these figures are those people that we harm or kill because not related to their disease. So it's important to understand that this is about true error. And here's one of the big problems, and this is, we need to focus on the 9% of physicians account for 50% of the complaints. So if we focus on the group that's struggling to provide excellent care, then we can really do a lot to help reduce error. And this was one of my professors at Harvard, Lucien Leap, who was a pediatric surgeon, but in his latter years of retirement, he published on medical error and was one of the first persons to do so. He said the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And to err is human, to blame it on somebody else is even more human. So that's kind of the nature of the beast. And this is his paper in the JAMA in 1991, which he was very reluctant to publish because he thought the medical profession would be out to get him for this. And it was really about the incidence of error in medicine from a study that they did in New York State. And basically what he has come out to say after all this evaluation of these issues, he said physicians, nurses, and of course other providers need to accept that the notion of error is an inevitable accompaniment of the human condition, even among conscientious professionals with high standards. Errors must be accepted as evidence of system flaws, not character flaws. So the idea that medical errors are caused by bad systems is a really transforming concept. And we've learned from cognitive psychology, errors are normal. And the causes are not obscure. So here are some of the causes of error: habit, interruptions. So doing things without thinking about it. Interruptions, we've done studies on interruptions in the operating room. To ask questions and telephone calls in, having to hurry, multiple patients, fatigue, anger, anxiety, boredom, and fear. Fear of doing something wrong can actually create a problem. So why is medicine so susceptible to errors? It's because really a lot of people are just not aware of the problem because errors happen, but for the individual physician, they don't see it that often. And there is a culture of silence, a blame and shame mentality still exists, and then system constraints. And this is the biggest problem in the Canadian healthcare system: staffing problems, nursing issues, fatigue, burnout. The knowledge requirements are increasing for all professions, communication, continuity of care, all kinds of issues. And so what are the solutions? We've heard about the checklist manifesto, and we've learned that from aviation, but other industries, nuclear power, military. IT was held out 20 years ago as one of the things that would really, really help reduce error. We haven't seen that yet, but less reliance on memory, computerized provider order entries obviously can help with poor handwriting and transcription of orders. Restriction of working hours, that hasn't actually worked out as well as we thought. And greater staffing to patient ratios. We know that if you reduce the nursing ratios on medical or surgical floors, that the mortality rate goes up. So what we're doing is squeezing hospitals in Ontario and across Canada, and this is driving nurses out of the profession, and it is creating a risky environment. And of course, the organizational culture is important. So I'm now circling back to my objectives. So I hope now you have a good understanding of the elements of medical negligence. And I've talked about how we bring ethics into informed consent and care, and then tied in the medical error issue and the problems that we have that create the harm to patients and result in litigation. So I hope I've come full circle. And the elephant in the room, I think, though, for physicians is how we're compensated and how we work and how we train. But I think ultimately we need lots of different things to help all providers provide the best and the safest care. So thank you very much for listening to this, and I'm happy to take any questions. And I gather Andrea and Terry are coming up with some questions.
Yes, we are certainly on it. And thank you so much, Dr. Leyland, for that fascinating talk. I do want to just remind the audience that, of course, it's time for questions and discussion via the YouTube chat. So please feel free to insert your question on YouTube, and then they will be transferred over to me to read out. If you aren't logged into YouTube and you want to send in a question, then you can email any question you have to jcb.ea@utoronto.ca, and I believe that this information is also put in the chat. So I will just turn to the questions right now, and I'll just get us kicked off. Around this notion, Dr. Leyland, of actual and proximate causation, and around the fact that in order for a plaintiff to actually succeed in a medical malpractice case, expert testimony is needed. And my understanding is that that expert testimony is needed to provide information about the standard of care and the plausible causation of the act and the actual harm endured, or the potential harm endured. And so my question is that in the field of gynecology and obstetrics, just given the rapid advances that have and continue to occur within that field, is it currently the case that standards are changing? And if so, is it difficult? Does that pose some difficulty to determine if an injury has been directly caused by a new intervention? Are there enough people who can speak as experts about these new advancements? So I'll leave it there. I would love your thoughts.
Yeah, so there's a lot to unpack in your question, and it's a really great number of questions. I think with respect to standards, they are changing. And one of the things that we do with clinical practice guidelines is we try to keep up with the changes and to be able to provide an accessible, readable, and easily gleaned process for clinicians in practice to be able to learn about these changes. So for example, in fetal health surveillance, There are various changes in terms of terminology and that sort of stuff. The basics don't change that much generally, but by and large, some of the terminology and how we intervene and that sort of thing can change. But I think the biggest challenge is making it easy for really busy clinicians to keep up with all of this new information. And that's the biggest challenge for us when we create our guidelines. So we do have strategies to try to get the educational process going, but often these guidelines are very long and they're very difficult to read. So we are trying to make them more algorithmic, things that they can have on the wall and just look at, or even on handheld devices to be able to access this kind of stuff, because it is difficult for people to keep up. But I don't think it's as big a challenge in our specialty as you might think, because of the locality rule. So there are some things that are not available to clinicians practicing not that far from major academic medical centers. It's surprising how you don't have to go too far before you're starting to see not good access to blood banks and lots of other aspects of that are easy to. So also when we create these guidelines, we want to do it from the perspective of all providers. So we're not making the expectations so over the top that they couldn't possibly provide appropriate care for these patients. So it is difficult. The causation issue and all of these things make it difficult for plaintiffs to actually win the cases. So you really have to be certain that you've got all the ducks in a row from a plaintiff's point of view. And when you said experts, a big problem, particularly in the United States, less so, but it still is an issue in Canada, is some lawyers do plaintiff's case, some lawyers do work with the CMPA, but doctors, the court actually finds it more credible when you've done work for both the CMPA and for plaintiffs. So I think it's important for people doing that kind of expert testimony that you're not a hired gun, because you are not working for either the CMPA or the plaintiff. You are working to communicate with the court, and most of the time, it's in Canada, it's a judge. So you're trying to educate the judge on all of the issues. So you're not trying to win the case on the basis of, whatever. You're trying to win it or lose it on the basis of the facts and the information. So I think we want to make sure that clinicians who get involved in expert testimony really understand that.
Thank you so much for that response. And so we do have a few questions. So one of them that came in through YouTube, just thanking you certainly for such a clear and effective talk. This person says, I'm curious about physicians' fear of litigation when asked for a tubal sterilization from someone who is young and childless. Yeah. Can post-sterilization regret be considered an injury or some kind of an emotional damage? The informed consent process is easier said than done, since no one knows for sure how they're going to feel down the road post-sterilization. And additionally, of course, contraceptive alternatives exist, but sometimes patients may request sterilization for various reasons. What are your thoughts on this?
Yeah, it's a really interesting area. So tubal ligation regret is a real thing, and it is definitely correlated with the age of the patient at which they made the decision to do this. So, here's an issue of autonomy, and also whether or not physicians are required to do what patients request. So, and we are not. And I often tell our trainees, we're not technicians. We don't, people can't tell us that they want this done and you should do it. I think that we have the right under most circumstances to be able to say, I don't feel comfortable doing this, that whatever it is, but you do have an obligation to send them for additional opinions about whatever it is. With respect to tubal ligation, because they are very effective methods of long-term contraception. So the intrauterine systems are really actually extremely beneficial for patients. Some patients don't like a foreign body in their uterus, but it's very effective. But also oral contraceptives, Depo-Provera, there are all kinds, and some of the newer injectable progestins. So when we're faced with a patient like that, it is a difficult conversation. But unfortunately, for some patients, and they do get upset about it, we don't have the obligation to do necessarily what a patient requests if we don't think it's in the patient's best interest. So, I mean, there are going to be always exceptions to every rule, and we have to take that into consideration. We want to have patient-centered care, but at the same time, it's important for physicians to realize that they're not just technicians. They have a professional obligation both through their own moral and ethical framework, as well as what's considered the standard of care for patients. So it's a difficult question, though. There was a flurry of stuff about 5 or 6 years ago about this because there was a patient who was very upset who couldn't get the tubal ligation when she requested it at a young age.
Very interesting. Thank you so much. Another person said thank you for the lecture, of course. And based on the fact that it is human to err, can we, or perhaps should we, then look at no-fault compensation as an alternative to litigation, since the chances of a plaintiff's success is quite slim?
Yeah, I think that is the direction that our society should go in, because there are circumstances where things happened. I mentioned that triplets with problem, and obviously those children have all kinds of costs and issues that are not necessarily satisfactorily provided by our government healthcare system. So yeah, I think that's the direction that we need to go. But at the same time, if there were no fault insurance and the doctors were kind of open to not being sued, and I think we still need to look at all the mechanisms that I was talking about to try to prevent error in the first place, because obviously patients being harmed is the thing that we want to prevent. And I think there's a lot more we can do based on other industries and based on the concepts that we already know, that we need to do a better job in preventing injuries and errors to patients.
Thank you. Another question is reflecting upon this concept of non-maleficence, which was appropriately defined as not intentionally harming or disadvantaging a patient. And so the question is, how much weight do you think, so it is somewhat related to the question that was just posed, but how much weight do you think a person's intention should have when it comes to determining if they're blameworthy, since it's presumably the case that most physicians don't intend on harming anyone?
Yeah, well, there have been circumstances where physicians have intentionally harmed patients, but those are really, really rare. The concept of blame is really about did someone cause this because they didn't do the right thing at the right time for the right patient? And that is can be defined as negligence. But just because something bad happens doesn't mean that there's negligence. And so that's why when you go through all the elements of it, yeah, you can blame the doctor, and the doctor should take the responsibility and say, yes, I caused this injury, but it occurred as a result of what we would say would be an acceptable risk. So in pelvic surgery, we have to be extremely careful with the ureters. But we do tell patients that even though in the best of hands, when we do everything we possibly can to protect that ureter, something might happen, because there are some things that are out of our hands, even though we're doing the surgery. Because we often show videos in medical legal cases, and people think it's like the anatomy textbooks where the ureter is green and this is that, and you can see where it is. In fact, it all looks like the same stuff. So it's all bloody mess when you are doing surgery. So it's easy to understand how even in the best surgical hands with variations in anatomy and that sort of thing, that things can go wrong. So, but the perspective of the patient is, well, something happened, it's wrong, so you're at fault. And so that's the real question where patients get angry. And I think that that's where we as clinicians really need to communicate with patients, particularly after the fact. So often they go to another service and they're looked after there. If something bad has happened for a patient of mine, I always tell the fellows, you've got to go and see that patient every day. Because what happens with negligence cases is when the plaintiff gets upset because they think they're withholding something because they're not seeing them and not talking to them. And in the past, the CMPA said, don't have any communication with the patient. Well, I would disagree with that. I think keeping up the lines of communication and also showing appropriate empathy and regret. But that's even an apology like that is not an admission of negligence. It's just that, yeah, I was there, it happened, and I'm really sorry. And most of the time, even if you're in those circumstances, it's disconnecting from the patient, and then other people start to impugn the care of the provider. And it's often people with some medical knowledge, and they're upset and they feed into the being upset with the patient. And in some cases, they think that they warrant significant financial compensation.
Thank you. That's incredibly interesting, even from my own perspective and reflections, just this concept of blame and blameworthiness, and that it may occur irrespective of negligence. It may occur simply because the desired outcome was not, in fact, achieved. Yeah, so no, incredibly interesting. I see, okay, another question, of course, another thank you. Seems like people really enjoyed your talk, of course, as did I. Can you comment about challenges in medical litigation in vulnerable populations, such as Indigenous communities, migrants, refugees, and in under-resourced areas? So I'm not sure if you can speak about that generally. Perhaps you've seen certain cases or recognize that there may be some vulnerabilities amongst these populations when it comes to gynecology and obstetrics.
Yeah. Well, I think actually just in general with respect to medical malpractice, it really is often about education and communication. So the challenge with refugees would be, English may not be their primary tongue. And so communication and understanding how to navigate the system. And also the issue of compensation and contingency-based compensation. So a lot of these people are really marginalized group, just don't get access to this. So I think we need to make the system more easily navigatable for these particular patients and the Indigenous population as well. We work closely with 6 Nations here, and since coming from Toronto, I've learned an awful lot about Indigenous history and some incredible things from some really amazing people. But again, they don't get the same education with respect to how to navigate the healthcare system or the medical legal system. It's hard enough to navigate the healthcare system for anyone, but for these particular groups, it's incredibly difficult. And even, I often say, if I have a medical problem that I need to go and see a doctor that's outside of my specialty, I'm back to, being like any other person trying to navigate the system. It's really difficult. In my area, I know how to get to various people, but I can't imagine the people who may have difficult communicating in English and that sort of thing. So we need to figure out how to make that system better.
Thank you. And I think you've given some really great suggestions and ways to respond to persons in situations of vulnerability. Certainly, Another question, I'm just scrolling through. Oh, okay, a question just came in around perhaps what percentage of cases where a family is known to have a genetically dominant disease and a physician fails to give the opportunity for testing to family members. So I'm not sure if you want to comment on these sorts of cases perhaps being brought forward to trial. Of course. Yeah.
So I'm not familiar with those cases in particular. Most of the cases that I get involved with are surgically oriented or sometimes obstetrical, but that particular issue is critical. If there is a family history, when you're taking the obstetrical history, that you need to understand the pedigree and to understand the risks of those things that you need to be checking for with respect to genetic and prenatal diagnostic testing. So this is not my area, but it sounds like if somebody missed the diagnosis that they ought to have made, that would have been negligent, really. They needed to inform the patient of the options for testing and investigation.
Thank you. And it's 4:56, maybe time for one or two more questions if you're okay with that, Dr. Leyland. Yeah. Great. So one question is just, it's interesting and surprising that 90% of doctors who are sued are in gynecology and obstetrics. As you mentioned, perhaps at least part of the reason is because another being, namely a baby, is presumably involved in the harm. And so the question is, do you think that it's likely the case that there's actually a lot more medical errors occurring in other areas of medicine, but because the harms may only involve one individual, are less emotional than when a baby is also harmed, medical malpractice lawsuits simply aren't filed?
Yeah, it's certainly possible. I don't know, and I don't have any particular information to back that up, but it certainly is logical and makes sense. With respect to obstetrical care, the challenge really is we don't yet have definitive tools to tell us when the baby is healthy and when it's not. We have tools such as fetal heart rate monitoring and scalp sampling and various things, but it's all it's all about probability. So, and also what's called normalized aberrance. So when we see fetal heart rate tracings that look crappy and you get a screaming baby that's very healthy and happy, you see that 9 times out of 10, but one of them is going to be a baby that's having real struggles. So it's trying to figure out who to intervene on and who not to. And then sometimes when you see a lot of normal coming out of abnormal appearing fetal heart rate tracings, you're inclined to say, oh, you know, I think we can wait a little bit longer. And then it's just that we don't yet have the tools to make it. So I think that's why error or bad outcomes still happen in obstetrics, because there's some of them that are just not preventable.
Thank you. All right, so I'm saying it's 4:59 right now, and I think we got through all of the questions, but if not, then perhaps we can email you afterwards, Dr. Leyland, just at least for your knowledge and reflection that these questions did come in. And certainly this motivated and inspired a lot of interesting discussion and thoughtful questions, I think. So that was great. Thank you for taking that time. And unfortunately, it's time to draw today's seminar to a close. So I just have a couple of brief announcements to make before we formally thank our speaker. Our next seminar will be taking place on Wednesday, February 16th at the same time, where C. Dalrymple Fraser will be discussing reconsidering suicide, a morbid approach. To sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. And of course, CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. Dr. Leyland, on behalf of all of us, thank you very much for taking the time to share your insights and expertise with us. We really appreciate it.
Well, thank you very much. It was my pleasure. Okay, have a good night.